Okay, so this for pancreas, it's gonna be a lot shorter than yesterday. It's just there's just not as much, I suppose, content on it. It's mostly just gonna be a quick overview of normal pancreas function, talking about acute pancreatitis, necrotizing, general management, chronic, and just a little bit on pancreatic cancer. It's probably pancreatic cancer was probably the least pertinent overall. It was more about kind of like this general management. Okay, so here I kind of wrote down some of the normal pancreas functions. Um, we know it's involved in production of glucagon, insulin. The exact cells it comes from, not really relevant, but it's just there for extra information. But we know glucagon, it makes glucagon to stimulate the release of more glucose by breaking down glycogen from the liver stores. Insulin is there, therefore is then used to put that sugar into the cells and take excess sugar and then convert it into glycogen to store in the liver. Another hormone that it makes is the somatostatin. That's the octreotide is an analog of it. So the somatostatin that we talked about for esophageal varices when there's an active bleed, this is the same hormone essentially. So it has a few other purposes other than that causing that vasoconstriction. It also has the purpose of inhibiting some of the release of the pancreatic hormone. So that's kind of it's one of its purposes is to inhibit the pancreatic enzymes, such as written here, the lipase, which is there to break down. ACE in general is for any enzyme, so things that break things down. Lip or lip is for lipids, so fats. Protease would be breaking some hormone that breaks down proteins. Amylase, like amylin would be like breakdown of starch. So basically covers the three major groups, helps you hormones that help you break down fat, protein, starches, and then it's also going to be a production center for bicarbonate. So that's something that helps to manage your acid base balance. Um, so this is where the bicarbonate's actually produced. Later on, when you guys go over kidneys, the kidneys also is involved with bicarbonate, not so much the production, but with the management. So the kidneys will waste or keep bicarbonate depending on what the body needs, but the actual production of it comes from the pancreas. So essentially, the pancreas has functions with glucose regulation, metabolism with these, as well as acid-base balance. Okay, that's a general overview. For acute pancreatitis, I have the ref definition down, and we're gonna have you guys talk about the causes and some of the signs and symptoms. So the definition would be the sudden, so the key word there is sudden, severe inflammation of the pancreas. So it's an acute inflammation. A lot of it is due to those digestive enzymes activating when they shouldn't, leading to auto-digestion of the pancreas. Auto meaning self, so pancreas is basically digesting itself. So what are some causes that you guys remember for acute pancreatitis? I do like his acronym. There are a few of those, of course, that are a little forced, just so that he could say get smashed. But probably the most important and more common ones that you guys mentioned there be the gallstones, alcohol, so the ETOH, so alcohol, probably some of the main two, and then as alongside triglycerides, so a high triglyceride count, gonna be the main causes. But your biggest focus overall will be your gallstones and alcohol. Um, so probably put more specific, like high triglycerides here. And for some of the reasonings, your gallstones are have the potential to block the CBD, that's the common bile duct, um, leading to, so I like the arrows better actually. Block CBD, leading to the backing up of enzymes. Because if we remember from our little picture from yesterday, if I can bring it up, we see, I guess it wasn't the main one I showed, but we saw that that whole connection, we have the hepatic duct, we have the common bile duct, and the pancreatic duct all connect to each other. So if you're having blockage of the common bile duct, then you can start having um, blockage with the pancreas. So this is the picture we had yesterday. I'll bring it in. This one again. So basically the same idea here. A lot of these kind of work together, and when one's affected, it can affect the others. So this one here would be the cystic duct, which connects to the gallbladder. Um, if this is here, there's an obstruction, it can lead to blockage, and that's why with um, gallstones, if it gets stuck here, it can lead to liver obstruction because you can see how close the hepatic duct is to if it got stuck in here. If it gets stuck here, then in the common bile duct, this one connects to everything. That's why it's called a common bile duct because it just kind of connects to um, essentially like all three of them at the same time. Connects here, here, and here. If you get stuck here, that's when you can have kind of like a triple issue. If it gets stuck a little bit down here, especially at the pancreatic duct, that's when you can start having issues with your pancreas more than anything. But if you have like a gallstone obstructing the common bile duct, you'll probably have issues with all three. The gallstone is kind of already like we already know that's the cause, so that's something with your gallbladder to begin with, and then that obstruction leading to issues with your liver, issues with your pancreas. So I like the picture just because you kind of get that general idea. Okay. And then the alcohol damages the pancreas. So this leads to inflammation directly. Okay. Let's see here. I know there's other ones he mentioned. So other stuff that are there with your get smashed would be the traumas, autoimmune, certain drugs, um, ERCP, so someone, yeah, mumps as well. A lot of different stuff, but I think these are the main ones to really focus more on. Yeah, there's like, yeah, random scorpion bites. Pregnancy, I think, was one of them as well. Hypercalcemia. Hypercalcemia leading to calcium deposits, which then leads to pancreatitis, which then ironically then leads to the saponification, but we'll get more onto that. But these are your main three. These are the ones I would focus the hardest on. But other causes would be, yeah, like we said, trauma, steroid use, steroids as in like corticosteroids more than anything. Mom's autoimmune, but these are the lesser. I would say these are lesser. So what are some of the signs and symptoms that you can expect with your pancreatitis? So the few, yeah. So one of the things that's gonna bring them in immediately is gonna be the pain. So that's kind of maybe like one of the you could maybe argue one of the good things is that one of the main signs is pain, so they'll actually go to the hospital because there's a lot of conditions where pain is more of a something that happens later on, and people will have other symptoms and they won't come in. But with this one, the pain is one of like the main um things that's caused by it. So people come in because of it, so we can treat it earlier. And yeah, Ryan mentions the boring pain. I always think that's a funny word to describe pain, but it basically just means like a dull pain, which is kind of funny because dull and boring can be used in that way. Like if something is boring, it's also dull. So that's kind of a definition of like a sudden dull kind of pain. So that is one of the big manifestations there. So let's see here. And yes, it can radiate to the back. And something else, it's worse when the patient is flat. Says this almost seems like the right case we would treat pain first, be a bowel arrest. I mean, and technically all those stuff isn't like necessarily like directly like it's gonna help with the pain, but it's like you would do those even if they didn't have any pain kind of thing, right? Like the bowel resting is so that you're not stressing out the pancreas, and you will decrease the pain alongside of that, but it's not like you get what I'm saying? It's like the pain is like a consequence of the other stuff. You're treating the other stuff, and that leads to the pain being decreased, but you're not like directly like it's not your focus is the pain per se, but it's like the other stuff that causes the pain. Someone else, let's see what else. Yes, nausea, vomiting, abdominal tenderness. Yes. Trying to find like another analogy for it that might help. Yeah. Yeah. But for now, just kind of write down all that we were talking about first, and I'll talk about it later. So yeah, there's that transient hyperglycemia, like Jessica, and I think someone else mentioned it as well. It's just Jessica. Yeah, there's like a transient hyperglycemia. So with the fact that the pancreas is not working too good, it's also not really able to release uh insulin. It's struggling to produce insulin, yeah. So whatever you're eating, or like whatever you have eaten or whatnot, your body wasn't able to utilize the glucose with that. Someone mentioned jaundice, so yes, so this is related to the obstructiveness. Remember the connection you have here, like I talked about. If you have anything going on, either in the common bile duct or it can even happen in the pancreatic duct, because over time, it's going to lead to just long-term obstruction coming up. So over time, it can lead to liver obstruction. Um, see what else people say. Yeah, so that's going to be a thing in terms of assessing for complications. It's going to be your biggest priority just because it's an airway potential issue. You have like a few major ones. So you have lung. I think, let me see what else. Someone already mentioned bleeding. So the Cullen and Turner sign, um, as well as shock and stuff. So the way I like to think of it is, just let me just catch up on the thing. So someone said tachy and hypo. Yeah, so that's kind of all going with some of the other like big complications. So I'll kind of mention it kind of here. Um, so a lot of that pretty much comes from, well, at least two of the three major ones come from the formation of fistulas. Is this a sign and symptom or complication? Um, I would say it's kind of more of a complication, I suppose. So not you're not always gonna have hypocalcemia. It's not gonna happen. I don't believe it happens immediately. It's gonna take a little bit because you have the calcium soaping, the saponification. If it is happening, it's indicative that the prognosis isn't very good, and there's a lot that goes with it. Um, but I think like a big one is fistulas. So we talked about lung complication. That kind of I would say goes under lung and um kind of lung complication. I'll explain in a little bit. I'm just trying to catch up to the chat right now. Yeah, because there's also necrotizing pancreatitis. So we talked about bleeding. So the fistulas is probably just do like this. So necrotizing, because there's a lot of stuff there. So necrotizing pancreatitis. So that's one of the main complications. So I guess here we'll put manifestations, complications. Just kind of ease it out. Yeah. Sorry, it's just there's a lot of stuff here. I'm just trying to make it make sense. Organize it in a good way that makes sense. So maybe I will split them up because I think it's gonna make it a little bit easier. So fistulas, and that leads to a lot of other stuff. I would say hypocalcemia is probably more of a complication. So another thing we've mentioned, nausea, vomiting. Another one I would say I don't think got mentioned would be the staturia because if you're having issues with production of lipase, because that's one of your hormones that your pancreas makes, then you're also struggling to break down fats. So you have those clay-colored stools, the fatty, stinky stools. They mentioned ileus. Honestly, I don't even know what that's referring to. Just said ileus. Let me see what that's. Oh, okay. It's like lack of peristalsis. Surely there's a better word for that. Let's see. I guess that's just what it's called. I was thinking like a different word. Yeah, it just slows down. Huh. Because I know there's like the diabetic paralytic ileus. I guess that's what that is, huh? Like similar concept. Basically, yes, hypoactive bowels. So I'd probably just but I guess that's good that you knew the 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 weird word for it. So if it comes up, you're like, what is that? Right? So I'll write it down. So what's a potential manifestation? So ileus would be essentially hypoactive bowels. So now you know the technical term for it. Let me see what else we can include in here. Um, in terms of just general stuff, he's mentioned pseudocysts. Probably just put that in here. Pseudocysts, nausea, vomiting, about hypocalcemia. All right, so we then from this, that's pretty much the idea. So the main thing you'll notice with these people would be that epigastric left upper extremity pain, because that's where the pancreas is, can radiate to the back. They'll have nausea, vomiting, so we're gonna want to rest the bowels. That's gonna be one of your main things. You're gonna have hypoactive bowels. Oh, sorry, so the lack of lipase leading to fatty stools. Anything else that we can include for this? Otherwise, a lot of it's going to be focused on complications. So with the fistulas, you kind of have fistulas going to the lungs and then fistulas going to the stomach. So this is fistulas between pancreas and blank. So essentially, what this is referring to is that the pancreas is self-digesting itself. So with that digestion, it can lead to essentially making a hole through this either the lung or the stomach, and then kind of having a pathway for your pancreatic stuff or all your stuff in there to kind of mix and match. Be sharp and acute pancreatitis. Chronic pancreatitis will have the boring, dull pain. I guess that makes sense like that if you want to think of it like that. Probably, yeah. The sudden painful. I'm not sure about the actual feeling, but I'll double check up on that. But I think the more important thing is just kind of knowing that where the feeling is, the fact that pain is occurring, but I'll double check up on that. So yeah, tell me about the fistulas here. What do you guys know about this while I look that up? Okay, so let's see what you guys got. Yeah, so when it comes to the lungs, that's kind of what's going to happen is it can lead to pleural effusions, exactly. So essentially pancreas and the lungs will probably more so like the technically the pleural space. Um, it can potentially lead to pleural effusion leading to ARDS, yes. So that's kind of the issues with that. And ARDS is a very serious thing. Patient will have to be intubated more than likely with ARDS. So yeah, so essentially between probably more I could say the pleural space than anything. So pleural effusions, the difference between pleural effusion and pulmonary edema, meaning is where the fluid is. So if it's in the pleural space, pleural effusion. If it's in the actual lung itself, then that's your pulmonary edema. Pleural effusion. What about when it gets to the stomach? Yeah, fingers is right next to the lungs as well. And yeah, pleural effusion, so that's potential risk for ARDS. And when you have ARDS, big bad. You'll learn more about acute respiratory distress syndrome in the next semester. So what about with the stomach? Sure, we're gonna want to rest the bowels. So what happens if there's like again like a fistula between the stomach and the pancreas? So you have all of those contents kind of mixing with each other. Yeah, exactly. So that's where the peritonitis comes in. So the stomach, that fistula with the stomach is then potential risk of peritonitis. So that's kind of how I break it down is I think of one of your big complications is the fistulas, and the fistulas will then either like, you get gunk in the pleural space, increased risk of ARDS. ARDS a lot of time can be brought up by infection. So sepsis is like one of the number one causes of ARDS. And if it gets to the stomach, you can get the peritonitis, which we've talked about extensively before in previous classes. But you have that rigid board-like abdomen and whatnot. So that one can also just lead straight to sepsis. It's big area that um, is being hit with the all the bacteria coming in. And we do have we do have a section on necrotizing pancreatitis, but kind of in the name, necrotizing, essentially you have internalized bleeding. So someone mentioned tachy and hypo, so that's kind of a complication of the complication. So with necrotizing pancreatitis, you have a few things. So you have the increased risk of shock, or well, yes, shock, and infection, as you can imagine from your pancreas killing itself and dying um, and whatnot. So in severe cases, that's where that necrotizing pancreatitis comes in. That's where you have the different signs. Um, so a way to think about the colons and grays, yeah, basically, so between the colons and grays is you can a colon starts with a C. You can wrap that C around your belly button. So that's the colons, and then the gray turners is in the flanks. So you have to turn them to see it. That's like a way to remember it. So for gray turners, you have to turn them because it's in the flanks, and then for colon sign, you have that C around your belly button. See if I can get a good picture of that. Sweet. So yeah, you gotta have that C with the colons, and you have to turn them around to get to the flanks for the turners. And there's other ones. There's the Fox's sign, whatnot, but the main emphasis would just be on these two for now. But of course, if you are having internal bleeding, that's where that shock comes in. If you're having portal of entry, you have your pancreas essentially sludge like eating itself, um, essentially like not so much bursting, but essentially like melting onto itself, kind of. So you'll have different things. Yeah. So maybe if you are having internalized bleeding in your stomach or your flanks, you might what do you think you might see on the person physically, other than the color? Sure, you'll have ecchymosis, like bluish ecchymosis. What else would you might expect? Like if someone's bleeding into a specific area, swelling, yeah. So that you might have like an increase in like abdominal girth or something. Um, because maybe they're internally bleeding. So you'll see the internal bleeding. You'll see the kind of the bluish ecchymosis, like Ryan mentioned, and swelling. A few other people. Yeah, I'm sure. Yeah, you will probably have pallor. So you'll have like you think about your typical bleeding. So patient could be pale, altered level of consciousness, change in vital signs, compensation. So a lot of like the shock. So tachycardia, change in pulse quality, increased respirations. But because you're internally bleeding into a specific area, you could have swelling. So like maybe increase abdominal girth or something. Does that make sense on that? Hypnea. And then you might have varying changes in blood pressure depending on what stage of shock, if they're in shock, like what stage of shock they're in. So you might already have the big drop, or you might have that instance where you have systolic relatively normal, but with an increased diastolic because your body's clamping down and it's managing to compensate initially before the big decrease. So that's kind of like the main one. BP, usually like narrowing pulse pressure is what they call it. I don't remember if this is the class we talked like a decent amount about shock or not. There's 220. Yeah, yeah. I think it was yeah, it was 220 that we initially talked about shock, but I think in second semester they were learning about postpartum hemorrhage, so I think I really emphasized like shock, like if did a review for them on shock. So I guess it wasn't this class. So just kind of like general thing with shock is narrowing pulse pressure. So you could have, let's say someone has a blood pressure of 120 over 80, early shock. That you about see like that diastolic might stay relatively the same. Maybe it's still, let's say just for simplicity's sake, it's still 120, but maybe that diastolic might actually increase. because they're clamping or not clamping. They're no, they are yeah, clamping. They're clamping down. Their body is constricting to try to make up for what their loss of volume, and their systolic is still at this point compensating. So that's what that means by narrowing pulse pressure. So a change in the diastolic going up while the systolic stays relatively the same, or maybe it starts going down. So maybe over time it goes down to like 108 over um like 90, like 93 or something. Like basically the point is that they start getting closer and closer as your body is failing to compensate because the diastolic is your resting. So what reason does it have to be increasing the resting one if not for it just trying to clamp down, if that makes sense. But that's what that refers to. And your tachy because it's compensating, tachypnea because it's compensating. Um, but yeah, okay. Other things, other than just like the pseudocyst and stuff, we talked about ARDS, um, being one. With your sepsis, infection, so infection, sepsis, and sepsis can also lead to DIC. You have like this big inflammatory. Essentially, sepsis can lead to DIC and ARDS. So it's kind of all together. All kind of comes together. ARDS can be caused by sepsis. Sepsis is one of the number one causes. Can be caused by direct lung trauma. So maybe you have this the fistula. Maybe this leads to that respiratory infection, sepsis, ARDS that way, or it ends up causing direct lung trauma, which can also lead to ARDS. ARDS is essentially caused by huge inflammatory um, cause. But again, that's extra info, but that's just kind of putting it all into perspective there. And then the hypocalcemia. So tell me what you guys remember about generally anything you remember about hypocalcemia. So why does this happen? And like what are some signs that we can look at? Yeah, they're both kind of like difficult to spell, huh? Yeah, so I think you guys hit everything um pretty much. The tetany, the muscle twitching. Sometimes it can be asymptomatic and stuff. Yeah, the different signs and stuff. Just because sometimes in saponification, you talked about it. Pretty much you hit all the points I was looking for there. So yeah, so some signs. So we can do signs and symptoms of hypocalcemia include the tetany, the numb face, muscle twitching, and then some of the signs include I have a picture of it as well. I like this picture for it. And you guys were talking about, yeah, the saponification. You guys even explain why it happens. Essentially, let me see if someone like, yeah, Ryan's trying to talk about it right now. So the fatty acid, yeah, essentially, one of your hormones that we release, the pancreas makes is the lipase. The lipase, then when the pancreas is eating itself, essentially causes a breakdown of the fatty acids in the pancreas, and then those free um, fatty acids then bind to the calcium and kind of have like the soapy, turns into like a little soapy kind of thing. So it's basically hypocalcemia due to all that the fatty acids in the pancreas binding to calcium. So it's using up the calcium. Okay, and then this is the picture here. Make it a little bit smaller. So you might see these words thrown around on tests and Kaplan's and whatnot. So the Vostok sign, apparently, I learned apparently the CH is silent. So the Vostok sign, when someone has hypocalcemia, you can tap them in the facial nerve, so like right around that little part where like the cheekbone is, might cause twitching of the facial muscle. Trousseau sign, I think that's pronounced trousseau. Saponification is essentially the lipase breaking down the pancreas, releasing fatty acids, and the fatty acids binding to the calcium. So it's this long process of things happening. One thing leads to another. And the Trousseau sign is basically the spasm of the hands and wrist after inflating the blood cuff, the pressure cuff. You have the little spasms. So these are the ones that are associated along with Tedney. That word comes up a lot on Kaplan. Trousseau sign, Vostok sign, Tedney, those come up a lot with hypocalcemia. So Kaplan really likes those words. Okay, and then yes, it's due to the caused by saponification. Essentially, lipase breaks down pancreatic tissue, fatty acids, fatty acids bind and use up calcium, and that leads to the soaping kind of effect. Calcium soaping. Okay. Any questions on anything so far?
Can you hear me?
Yeah.
Oh, sorry, sometimes my mic doesn't work. I do have a quick question. I think when we started, you said you talked about this maybe in a previous tutoring session, and I
hmm
didn't go to that one. Could you specify how the octreotide works?
Oh, yes. So it has a few different purposes. So the one I mentioned it prior, the octreotide was in reference to the liver outline. The liver, octreotide is a medication that can be given either um, IM or IV. Actually, I gave it in the hospital. I gave it IV. Um, and it's has a few different purposes. So here, as we can see, like on the, so say on the board, on the screen share, it's a hormone that your pancreas already makes. So in terms of pancreas, it's there to inhibit the release of the pancreatic hormones, which you can imagine is good if the issue is that your pancreas is releasing hormones when it shouldn't and kind of eating itself that way. In terms of liver, it also has like a vasoconstricting effect, which when you have active bleeding with the esophageal varices as a result of liver issues leading to portal hypertension, it's good to constrict so that the bleeding stops. So when you have, when you have a open bleeding thing, you want to put pressure on it. So it's the same concept. That's why a lot of your interventions for the esophageal varices include like the balloon tamponade, so that applies pressure to the area, ice water lava, like putting ice water, because the ice water is constricting, and the octreotide also has that constricting effect. On top of also having that effect where it can inhibit the release of the pancreatic hormones.
Oh, okay. So in this case, it's given to inhibit
Ye-
pancreatic enzymes.
Yeah, exactly. So in this
Okay.
case, yeah, basically
Eh,
it's the thing that keeps these in check. They're not in check, so you give it to keep them in check.
okay. All right. Thank you.
hmm
So I have a question going off of that. So
Sure.
the somatostatin is the natural product, and then the octreotide is the synthetic one.
Yes,
And
exactly.
there's something called sandostatin. Is that just the other name?
I believe yes. So let me double check up on that.
I think that's the generic of
Yeah.
octreotide.
Oh, got it. Okay, thank you.
Yeah, so octreotide is the generic, sandostatin is the brand. Yeah. So, yep. So yes, octreotide is the synthetic somatostatin. The brand name is sandostatin. Basically all essentially the same thing. They're analogs, but they function practically the same way. And it has a lot of different purposes, but for here, those are the main ones we talk about. Apparently, it can also help with watery diarrhea and issues with um, growth hormone, but we don't worry about that. Yeah. All right. So, any questions on anything so far? Otherwise, we can move on to necrotizing pancreatitis. Although I would like to kind of just go over everything we talked about and just highlight what I think is probably important. Otherwise, just feel free to type it into the chat or say it out loud. So again, I think what's important is just kind of having this understanding because this can help you understand the like what the enzymes actually do. So breakdown of fats, proteins, and starches and stuff. So you can tell that, we need to be able to break those down so that our body can get nutrition. So this is going to be something that's going to affect your nutrition, especially more so with the chronic because it's going to be happening over long periods of time. So that's like an important thing to understand why there's that relationship between nutrition and pancreatitis. Bicarbonate, I think it's just good to know that your pancreas not working too good can lead to acid-base imbalances. So maybe like another thing that could be put in the complications could be like a metabolic acidosis. So that's something that could happen because if you're not making bicarbonate, you're kind of struggling. Let's see. Is tryptamine an enzyme that's ingested or something we can produce? Um, I believe it's something we make, but let me double check. If anything, isn't it amino acid? Let's see. I believe we produce it because it's a derivative of an amino acid. Maybe. I'm not sure if does tryptamine come up in here. Are you thinking of like trypsin? Let me double check all this stuff. These are all good questions. So trypsin is an enzyme that helps to break down proteins into smaller amino acids. Yeah, so the one of the enzymes you're thinking of is trypsin, which is one of the things we give. So not to be confused with the tryptamine. And yes, we do naturally make it. All right, cool. All right. So going back to that, we talked about that. I think having the understanding about how everything's connected here is good. So you can kind of visualize why having obstruction here is causing the involvement of the liver, causing the involvement. Yeah, metabolic acidosis. The idea would be go ahead, sorry.
Sorry, since we're on the picture, can you talk about how the ERCP can lead to pancreatitis? Is it just like, does it just cause inflammation in the bile
I
duct?
believe so, yes. I believe it's just kind of like when you're messing around with the area, it can lead to it. So sometimes heart surgeries can lead to the manipulation of the heart can then lead to irritation. So you can actually get like AFib after like a cabbage because you're manipulating the heart. So sometimes you'll have AFib coming from a cabbage, or you'll have um, is like peristalsis when you like someone manipulates the bowels and stuff. So the manipulation of the area, like Michelle just said, yeah, manipulation of the area can then lead to that inflammation, which makes
Oh,
sense,
okay.
right? Because you're touching it and cutting into
Yeah,
it.
yeah, I figured. I wanted to make sure if there was any other reason that
Yeah,
it
of
could
course.
be.
All right. Yeah, but just you guys kind of see because everything's connected, how that can lead to the involvement of the different organs. So it's all, so my body doesn't want to be poked and prodded, pretty much. Your main causes, you do have that get smashed. But the main focuses are the gallstones, the alcohol, triglycerides, and stuff. But there's you can still use the acronym for a lot. I think it's a funny acronym. So he has even funnier acronyms, but we'll get there when we get there. I like his acronyms, they're funny. Manifestations, yes, and that the pain. Oh, I don't think I ever got back to you, but yes, it seems that the acute is more associated with the sharp painful, and then the dull boring is more of the chronic. So I'll kind of fix that out. But I'm not sure if he's put us. I'm not sure if he put one of those in for acute or not. He might not have. I might have just kind of generalized everything. But just know it's painful in that left upper quadrant. Nausea, vomiting can happen. Hypoactive bowels, so you can see why we're resting the bowels. If you don't have lipase, you're going to get fatty stools. I think this is an important thing to think about is just how the pancreas can then lead to issues with your glucose regulation because you're not going to make insulin. So I think this is an important thing to think about is the transient hyperglycemia. The complications, definitely, I think the fistula and the necrotizing pancreatitis are going to be your biggest, some of your biggest things there to always want to think about and how you can relate um, these conditions to the fistulas themselves. So if you have that connection between the pancreas and the lungs, you're going to have pleural effusions that's going to lead to potentially ARDS. So that's where you need to get. So how do we deal with pleural effusions typically? What's an intervention to help with it? Yeah, the drainage. Yeah, the thoracentesis. Perfect. Awesome. And then with the stomach, risk of peritonitis. So that could be something that goes on to sepsis, and then sepsis leads to other stuff necrotizing pancreatitis. So if it ends up, the way I think of necrotizing pancreatitis is I think of literally like the pancreas melting itself. I kind of just think of like the pancreas just like melting onto itself. So obviously that's going to lead to bleeding, hemorrhaging, and if you're essentially antibiotics, pretty much, yeah, it's like essentially the peritonitis is pretty likely to end up causing a severe infection, so sepsis and stuff. So there's more that goes around to it. So you're gonna need like fluids, IV fluids. You're gonna need antibiotics, IV fluids. Because we know with sepsis you have that risk for not just hemorrhagic shock here, but also the septic shock. So your blood pressure ends up being a thing that we're worried about as well.
Does the pancreas does it store fat? Is that why the lipase is breaking it down in the pancreas?
That's a good question. I think it's just kind of like the makeup of the pancreas itself. I'll look that up though. I'm not confident on an answer. But let me
Okay,
look that up.
just wondering.
Any other questions on the same vein? Otherwise, we'll just kind of talk about. Oh yeah, I think this is also very important. Is understanding the internal bleeding is also a thing that needs to be assessed. So we know the obvious ones are like bluish ecchymosis, swelling. I think swelling is something to keep in mind. So they might have like you might want to see like it might be like kind of subtle. So maybe you want to check the abdominal girth or something. change in vital signs that kind of go with the shock and stuff. We talked about sepsis. It can lead to this other stuff. Hypocalcemia, the different things that Kaplan loves talking about, like tetany. I love talking about tetany, muscle twitching, and loves specifically talking about the names of the sign. Um, um, and then from there on out, the saponification. Let's see. Okay. Okay, so the specific thing that you were asking me is, does it hold fat? Not inside of it, but it will have fat surrounding it. So that saponification then would be the pancreas releasing some of those hormones, not just like inside like itself having like that necrotizing issue, but maybe just like around itself as well. So by doing that, it's going to break down some of the fats surrounding it. Um, Seems like fat is pretty abundant around the pancreas to begin with. So then those free fatty acids will then end up binding to the calcium and have that soapy saponification. So let me see if I can get a saponification pancreas, because saponification just means the making of soap. So let's see. Maybe you can see like a fatty pancreas. Yeah, pretty much. Yeah. It's just gonna be an organ where fat is pretty common. It does. I try to look it up and go give me how to make DIY soap. Yeah, yeah. Yeah, so essentially just I guess kind of like your liver, pancreas is also an organ that can have fats just kind of around it. Um and then that fat can also lead to some of the inflammation and issues, which is why that can be a common cause. It's all kind of building together now, I guess. It all makes sense. All right. I think that's everything for that. Yeah, so now you know about hypocalcemia, you know about little signs. All right. And then another thing that could be a consequence of the hypocalcemia, that irregularity in calcium, just like when you have an irregularity in magnesium or phosphorus or potassium, it can lead to heart dysrhythmias and stuff. But I think it does have to be pretty low for that or pretty high. So either low or high can lead to dysrhythmias. Can you Could you get pancreatitis if you get lipids via TPN and don't monitor the triglycerides? That's a great question. I honestly do have no, I don't even know where to start, actually. Um, you mean like acutely, huh? Like an acute thing where we like go too crazy on the lipids. That's a great question. I don't know the answer to that. I think that's a really good question for Mr. Robbins, though. He might know a little bit better on terms of that. I'll look it up when we have a little bit more free time. But for now, let's just move on to necrotizing pancreatitis. Can you explain about how pseudocystic abscess form? What's the difference in the progression of diagnosis or complication from the MIS, minimally invasive surgery? Um, Honestly, I don't know too much about the pseudocyst. So how do they form? The difference between a pseudocyst and an abscess. So the abscess would be essentially when you have a foreign pathogen or a foreign thing. In this case, I guess it'd be like a pathogen, and your body essentially surrounds it and kind of keeps it locked up into a little place. Um, which is why then they want to drain it, because the abscess can and essentially is containing a whole bunch of like bacteria inside. I believe the pseudocyst is caused. So a pseudocyst would essentially, as opposed to like an abscess essentially has like it's kind of like not synonymous with, but like more related to like an infection process, while the pseudocyst can just be formed due to inflammation, local damage and inflammation, maybe leading to like fluid buildup and stuff. So maybe um trying to see like the if that's like the technical definition, if there's anything else. But yeah, you don't have to know that deep on it though. So you can get pancreatitis just through rapid infusion. Do you know if that's a how long does it have does how long would it take for that to become a problem? Oh no, that was a question for Josh who looked up if you can get pancreatitis from rapid or like just from long-term TPN and stuff. Um, but but I believe definitely the main difference between an abscess and a pseudocyst is the fact that an abscess is going to have an infected region or infection with it. That's essentially the thing that makes it an abscess is that there's an infection that the body essentially surrounds and kept in check by essentially surrounding it. So it's going to have stuff like pus and bacteria, dead tissue and stuff. The pseudocyst might just be it could have non-infected stuff, fluid collection. So maybe like a difference between a blister and like an infected little like pimple or something. Yeah. I mean, again, this is not a focus like at all. That's like extra. Don't worry about it. It's not gonna be on the test. Don't worry about it. No, yeah, of course. I'm just saying, don't it's not on the test. Don't worry about it. Another difference between the pseudocyst and the abscess would be, like I said, like the big difference is that the abscess has infection, like an infected aspect to it. So you will need antibiotics and will probably need it will need drainage and you will need antibiotics because of the infection. The pseudocyst might only need like drainage. Okay. So now moving on to necrotizing pancreatitis, we said it's due to that autodigestion, infection, necrosis, fistulas. So this is like one of the main things that's causing some of this stuff. Essentially, that's kind of like the fistulas are caused by this essentially because it's making its way through and leading to all this. But it has its own little section just because there's some specific stuff um, for it here. Um, so let's see what you guys got on. Maybe what are some diagnostics that could be utilized? I'm gonna get some water real quick. Okay, so let's see what you guys got. Yeah, so some of your main pancreas labs that they look at would be your serum amylase and your serum lipase. So these are going to be high. Normally, we don't necessarily have lipase and amylase in our serum. So if they're high, it's a sign that it's starting to leak out into the general circulation. Yeah, so we talked about how you could have low calcium due to saponification, saponification. Some other labs that they'll do. Talk about the abdominal ultrasound. Yeah, so general abdominal ultrasound, ERCP, just it can help to both visualize and remove stones. Check if there's even anything there. CT scan, yes. So CT scan again to visualize stuff. Essentially, a lot of this stuff is like there to visualize. What else do we have here? Talked about the serum calcium. Someone mentioned the AST, ALT, so maybe the liver tests, just because you can have liver involvement. So LFT, so that's your ALT, AST, ALP. And the increased white blood cell or CRP due to inflammation. Most likely, yes, definitely. Um, yeah. So even if there is no infection, the white blood cell count could be elevated just because um, inflammation. And then triglycerides would be high because that's, yeah, triglycerides. Gonna be high because we're not really making lipase. Lipase is stuck not where it needs to be. If there's anything else that you guys mentioned. So Michelle said BAC. Are you referring to blood alcohol? Like, what is BAC?
Yes. Yes.
Okay. Oh, I think I get what you're saying because that's like a potential cause is like alcohol, or like what do you mean exactly?
Yeah, I was thinking that because it it can cause it.
I guess maybe. I don't know if they do. I mean, I guess maybe they could. I guess, at least in terms of lecture, I don't think it was mentioned, but I see where you're getting. I see where the thought process is though, for sure. We said CRP. Sorry, I forgot to write it down. CRP did the inflammation. Let me see. Let me catch up to chat again. Yeah, we said CRP. Jessica mentioned lactic acid, so that's another good one. Just because if someone does have an infection, lactic acid is something that we can do to assess if they have sepsis or something. But essentially, a lot of these are going to be your BMP or maybe CMP even, your complete metabolic panel. Mentioned that. Something someone I guess wasn't really mentioned is just high blood glucose because you're more likely to be hyper glycemic. Oh, did he? Okay, sure, sure. To rule out probably like alcohol. You call it an overdose? Um, so cause. Sure. Maybe I'll write out. I don't know if too many people know what that is. Blood alcohol. Yeah, blood alcohol level or blood alcohol concentration. I'll just call it blood alcohol. Mm, I think that's pretty much everything. If I had to say the key labs, it's definitely going to be these two here. Um, that's probably an important thing to keep in mind. Yes, sure, yeah. Yeah, so it gets a little bit more general stuff. Like I've been studying for the exam for the past several weeks. Yeah, it's kind of how it goes, huh? You pretty much, yeah, I remember, I think I was like Yeah, pretty much actually, yeah. It's like I get through the lecture and then I would pretty much already be studying for the test. That's kind of how that goes. Haven't gone outside all day. Honestly, me neither. We have to do Kaplan. We have to do like these really long Kaplan exams, and no matter what you get on it, you have to remediate. So we have to have a log of us remediating 150 questions, and then there's another, how many more? Another like 225 more to go. Yeah. Uh, let me see. Let me see where I'm at right now. I think I'm remediating question 106. The actual test took me 2 hours to do because it was 150 questions, and then the remediation has been like 4 hours. It's crazy. Oh man, that shit is so crazy. There's so much. There's so much busy work, but at least there's no stress. There's no stress. It's all busy work. So once you guys get here, it will just be all busy work, less stress. Let's see. Let's see. I think that's everything here. That's great. So what are your priorities here? Yeah, as always, that's going to be your priority. So we talked about how, especially like like your lung fistulas leading to respiratory issues. So you're really worried about that. You want to, yes, for sure, you want to be MPO and rest the bowels because you can imagine someone is having all this happen. They're probably not going to want to put food down their mouth, and also they might need to go down for like a surgery. So it just makes sense to be MPO to begin with. Manage the pain. Yeah, that's going to be one of the main things that bring them in. Iggy, well, not so much Iggy, but Kaplan loves talking about pain. I mean, yeah, I don't know, honestly. So there's some things where like Kaplan, there's some things where Kaplan just loves saying pain, but it just doesn't, I don't know, it's just like use your best judging nurses. I mean, I guess if I had to say this, it would be probably like, if it's not you would assess for complications, and if they don't have a complication, then you treat the pain. Right. In this scenario, that's pretty much, yeah. It's kind of like that, where like, obviously if this person's having respiratory issues, you're treating that. They're not always going to have respiratory issues. Um, I think I remember that because I think does he still do like the little tests, like the little in class not breakout room, little polls? Yeah, because I remember that being like a thing. He like really emphasized he wanted us to put like respiratory, even though like they're not always going to have respiratory. Um, yeah, that's like the general idea. I guess it's kind of like maybe think of it like this. If someone's coming in with pancreatitis, your priority is to rule out, you always want to do the ABCs. You rule out ABC issues. So now after you rule them out, then it's kind of managing the pain. They're not always going to come in with ABC issues. A lot of the people aren't coming in with ABC issues. Like maybe like another example could be like someone that has a fracture, right? Um, no matter what, you're always prioritizing ABCs because that's just how you're gonna save someone in an emergency. You're always making sure, can you breathe? Is your airway okay? Is your circulation good? And then after you've ruled stuff out, then you kind of move on to the other stuff. Yeah, pretty much. Like once you've ruled stuff out, like you would probably have this patient. They're in pain. You've done your preliminary baseline assessment. You've made sure that in terms of ABCs they're good, and now the rest of your priority is managing their pain and just making sure they don't have ABC issues. But if you guys get what I'm saying, it's just kind of like you're always making sure that something's not going wrong with ABCs. And for some patients, you could just do that by you walk into the room and you're like, you look good. I do like a 5 second, like a 10-second little mini assessment, and I can tell you're not in respiratory distress. And now I moved on and now I'm giving you your pain med. But yeah, just because he likes to emphasize that if that were to be a question, then you know what you should put. You should put what he said, essentially. Yeah, yeah. You know, it's all up to like nursing judgment at that point. Yeah, exactly. Sometimes it's just like, okay, you're big chilling on the bed, watching TV, eating a sandwich, or well, I guess in this case they wouldn't be eating a sandwich, really. Just, sometimes, there's some, not everything, sometimes during like emergencies and like codes and stuff, you feel like things happen out of nowhere, but sometimes there were like these little signs. So, that assessment is always important. So like maybe they felt like they were probably doing slightly okay. Maybe there's like slight subtle hints that something was going on, and that's why maybe he really emphasizes the ABCs for that. So maybe you thought this person was just kind of having issues with pain, but then because you didn't really make that good of an assessment on and trending like their respiratory stuff, like maybe they end up coding, and maybe you could have caught it just because it was like a subtle thing. If you guys get what I'm saying. I don't know. Maybe it happened to him. Maybe he had a uh pancreatitis patient, and like I don't know. The trending maybe wasn't there, and something happened and he's like, "Oh." But anyways, I think that's kind of where he's getting at though. It's just kind of you rule out if ABCs are an issue in your head or from your assessment, and then you manage whatever you can, that whatever you're seeing. Mm. Okay, anything else that we got here? Talked about resting the bowels. NGT for section. Yeah, decompressing the bowels, that's always good. NG2 to decompress the bowels. Would you see TPN administration? I would say if they have not been able to eat, or if they're MPO long enough. Yeah. Yeah, like pretty much, yeah. And manage their electrolytes, because if they're not eating, their potassium is probably going to be a little bit low. It does seem kind of long. I think in his power, I think the general, I think general when, and I think it's kind of contradictory. I think in the general TPN, they said 7+ days, and I think in this one specifically, he said 5 to 6. Yeah, up to judgment. I mean, a lot of this is going to be up to like nursing judgment. Um, to be determined. Yeah, pretty honestly, yes. Yeah, it's just yeah, it is how it do be. There's always a gray area. Yeah, pretty much. Let's see what you guys mentioned. So we tangent, compress the bowels. If they're antibiotics, maybe the flagyl. I spelled flagyl wrong. Boom. I believe he specified PO, but then like your MPO. I guess we could take that NG tube and then be like, okay, we're crushing this, and but then even then that doesn't really rest the bowels that way. Well, I guess in this case it's just like MPO accept meds or something. Some cultures do religious fasting for 7 days. That's true. I had a friend that had like during Ramadan, he had to fast. What he would do is he would change his sleep schedule, because I think they get like I believe they get like a time there's like a time period during the day where they get to eat. So he would change his sleep schedules so that he'd be asleep during the fasting. So he would just wake up and eat and then just go back to sleep. Um, But anyways, so and then you're gonna nutrition is gonna be there. You're gonna be IV fluids, TPN if MPO longer than. I think I would die from the. I think I could. I think the food would be okay, but I feel like without water, I would. I could not. I don't think I could. I don't think I could last. I don't think I could last very many hours without water. I think if I had to go multiple days, I would just actually die. Can't go long with a Diet Coke. Honestly, yeah, I've been like, you know, weaning off like energy drinks, right? I only have an energy drink during the night shift for preceptorship right now, weaning off them, but then I'm like drinking Diet Coke because it has caffeine in it. I know that's the reason my brain wants it really bad. And then I tell myself it's sugar free and it's okay. I can have another one. Yeah. Alrighty. Yeah. Moderation is always key for everything. Let's see. So let me see, make sure that we got everything here. I think that's pretty good. I think the only thing that's extra that he does mention would be um like talk about decreasing inflammation. So maybe some steroids or something can help. Oh, the sandostatin can be something that could be done for using. So the sandostatin, aka the octreotide. And then having good assessments for bleeding, respiratory issue, what's going to kill them first kind of idea. So again, it's kind of like the same thing. Pain meds, but not morphine. I think he did say that. Yeah, he specifically said no more. Morphine can cause like spasms and stuff. And then for your MPO, you have your PPIs and omeprazole prevent stress ulcers and stuff. Um, yeah, I think Protonics is pretty common, like IV Protonics. Try to prevent the stress ulcers. Yeah, Pepsid and stuff, Famotidine. So, PPIs, proton pump inhibitors, um, and the H2 blockers. Low fat, low sugar. Yeah, that's all good to go. So I can put that in there. It makes sense, right? Because again, that the fat is leading to some of the issues, and then if you're having hyperglycemia, that can be a thing as well. Probably put sugar here. There's a lot of stuff that goes into it, but I think personally that's why I like understanding the systems because I think it helps me. Um, but I think it's also important not to get lost in the sauce because sometimes you go too deep into it and you find like I'm not as good with it like Kaylin is. Kaylin is really good at really clustering things down into concepts. So she's able to really put everything into a concept and without having to like hard commit a lot of stuff to memory. She just kind of has general ideas. Yeah, it's just you can get lost. Yeah, I had one of my classmates. He always goes so deep into the rabbit hole for stuff. Um, and like he's always like just looking up everything he can and any little random thing that probably like you would like you. It's like one of those like you know for a fact this will not be on the test. But he still like tries to look it up. Um, yeah. But ironically for him, you know, he actually does good in the ER because he doesn't have time to spiral. It's kind of funny, you think the people that spiral usually are like ICU people, but in this case, like for him, ER works because it doesn't give him time to spiral. So I guess that's like an interesting little dynamic there. Yeah, so complications, we've talked about it a lot, so I'll kind of start filling stuff out. You talked about malnutrition. You can start having, when you're malnourished, the low albumin stuff. And then we have low albumin that's going to lead to potential third spacing if it gets really bad. You can have low calcium because you're gonna have, um, well, it's gonna be like low serum calcium because your albumin is one of the things that, how do you say, it can affect your calcium levels, which is why there's that corrected calcium formula that you also don't need to know. But that's like a little thing there. Dehydration, yeah, I would say so. Like that's where gotta give them the IP fluids and stuff. I'd say it's like a dehydration, probably just make it into like a hypovolemic shock. So like even more extreme here, like hypovolemic or septic shock. Um, Another thing is that you can technically get diabetes, uh, due to the damaged pancreas. What would you call this? Like would this technically be like type 1 technically because it's like a damaged pancreas. You're not making insulin. The book says both. They should make like a type 3. I don't know. Type 0.1 or
You know,
type.
I think there is one that's actually coined type 3. It's like
Oh, really?
pancreatic diabetes. Yeah, because I looked up if it causes type 1 or type 2 because the book said both, and it says there's a whole other one called type 3.
Interesting. Yeah. I learned recently that there's such thing as some fragile diabetes. I didn't know that was a thing. I don't know if anyone's ever heard of that. From what I gather is when you're like give me sense. Yeah. But I guess like in this case, like if your pancreas is damaged and you're not able to make insulin, technically it'd be like closer to a type 1, I would think. Yeah. I don't know. It's semantics. Like it's not important. Um, it's not really too important. It's just kind of I'm just wondering about the semantics. But yeah, so I started writing things down. We talked about respiratory stuff, story problems. So pleural effusions, ARDS, all that good stuff there. And then this can also be especially if they're especially like alcoholics, they have issues with malnutrition because of the alcohol. The alcohol damages some of the stomach lining and can lead to decreased absorption and stuff. If in the case that they are. What else? Infection, kind of infection, hemorrhaging. Yeah. So if they are hemorrhaging, so we talked about kind of the hypovolemic, but let's talk about hemorrhaging. What are some things you want to do if they are hemorrhaging? If they are hemorrhaging, like what do you want to ensure that they have? I guess let's before we kill them, like they start hemorrhaging, like what do you want to ensure that you have access to? Think back in your blood administration. Basically, what I'm trying to get at is what do you want to make sure this person who is at risk of bleeding has? Yeah, okay. I guess just maybe the framing was a little confusing. I meant like this patient's coming in with acute pancreatitis and they're not actively bleeding yet, but they are at a high risk for bleeding. So yeah, you want to be ensuring that they have 2 or more large bore cross and match. Yeah, so you want to get ahead of the game. So this is kind of how they might marry some of the concepts because you see that you know you the knowledge of like this person's risk of hemorrhaging, so you marry the ideas of blood transfusion with the pancreatitis, necrotizing pancreatitis. Um, Very much just prepare for the worst. You also might then when they're actually bleeding, then that's when we have target blood cells, you know, vasopressors, and you will learn more about these in the next rotation. So dopamine, levofed, aka norepinephrine. You'll learn more about it. Just for now, vasopressors is good enough. If you're having the issues with like hydration, having issues with blood pressure and stuff, then acute renal failure. So AKI, acute renal injury. Well, I guess it'd be acute kidney injury, but whatever. I don't know if that's if that's next week's or if that's a little bit further down the road. What do you guys have next week? Let me see. Oh, you have respiratory. Ew. I don't like respiratory that much. Renal's week 5. Okay. I like renal. Renal's cool. I like renal. I don't really like respiratory. It's always been like my worst subject. It's always been respiratory. Renal's a lot. Yeah. There's also a lot of extra info there that we can try to shave down. So when we get there, we'll shave a lot of it. We'll try to shave a lot of it down. Oh, you like respiratory? Oh, if you like respiratory, respiratory is a lot. It is a lot. I'm also splitting that into two, two sessions because it is a lot. Yeah, I don't like it either. Okay, I'm glad we all agree. Other complications that can be included here is the paralytic ileus that we talked about. Basically like hypoactive bowels. He emphasized this a few times. Who do we get when we go to fourth semester for tutors? As long as I'm not busy, I plan on staying. I'm gonna try to make it work because I want to maintain the connections because I want to work as a teacher in the future. And I don't want to be a nurse educator on the floor. I want to be a teacher at a school. So if I already have connections, I might as well like um I think it doesn't have to fully stop. It can be kind of hypoactive. It could be absent. Essentially the point is that they're not normal. They're not normal. And something that he likes to emphasize here. So essentially he wants you to monitor bowel sounds, bowel movements, gas. So if they're not able to pass gas, that's not a good thing. And he really specified to not give Bentyl. I don't remember if that ends up being like a test question or like an answer choice, but he said do not give Bentyl. That's a medication that is given for like irritable bowel disease. Yeah, that's a good one. Then yeah, that's a really good one. I like that. Cool. I like that. Do you guys have a test already? No, not yet, right? Your first test is this Friday, actually, right? Okay. What else do we got? I think we got a little bit of that. So we talked about hypocalcemia a lot. We talked about it a lot, so I'll just write it as a thing. And it's also increases risk of pancreatic cancer. But again, no need to have a PhD on pancreatic cancer. All right. So now we can just kind of go over general management. There's like non-surgical and surgical. Surprisingly, I guess I'm taking a little bit. So maybe I'll just kind of write it down. Actually, a lot of this is stuff we've been talking about. That's kind of the thing with these Robbins lectures is that it does get a little repetitive, but it's there for a reason. So a lot of the stuff we've been talking about, we talked about MPO, we talked about IV hydration, but now it's like now you can just kind of have it in like a little section and electrolyte replacement. Why? Because they're MPO. Bed rest, because we have that potential risk of lung complications. You also let me rephrase that. They're going to be want to be put to bed rest, kind of decrease the like all the movement and stuff. And so the person is going to want to prevent atelectasis because they're not moving around. So we're going to do DVT prophylaxis. We're going to make sure that they're not at risk for atelectasis and stuff. They're going to be, yeah, NG tube and stuff. NG tube for decompression. Talk about pain medications, GI medications. So that would be your PPIs, H2, maybe Sofran. We talked about Octrio. Oh, that's sorry. All right, that's octreotide. Maybe position, like good positioning. In which case, um, I guess lying on their side is one of the things. The digestive supplement feels they would tolerate PO. The digestive supplements typically would be for chronic pancreatitis more so than acute. But yeah, they would like to take them. And whenever, as soon as you're able to get enteral feeding happening, you want to do that. Otherwise, yeah, TPN if needed. And he specified for position is side lying. Anything else? Antibiotics if needed. A lot of this stuff is stuff that we've been talking about. He said, yeah, TPN if needed. Assessment of respiratory infection, blood glucose, all of that stuff is important. Surgical, they could do things if you're unresponsive to conservative therapy. So if we're doing all of this and it's not working, okay, let's see what's going on. Do you have do we have to remove gallstones? Do we have to drain a cyst, an abscess? Oh yeah, yeah. So he is specified for the positioning would be like side lying. What I meant was that MPO. Oh, sorry, I didn't even see. The justice supplements from business. What you meant was that MPO community test of fluid within the. Oh, okay, yeah, 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 yeah. Yes. Did I read the thing right? Maybe I read it wrong. The justice supplements. But yeah, side lying is a comfortable position because it helps to relieve some of the pressure on the inflamed pancreas and stuff instead of lying flat on their back. So remember, one of the things at the top was that that pain with the acute pancreatitis is worse when they're flat. So that's why, um, let me see, left or right side? That's a good question. I don't know if it matters. Let's see. I think the idea would just be to be on theirs.
Also,
I think
was
left side. Mhm.
fetal position one of them or no? I thought I read like they were in semi-Fowlers and then kind of fetal. I don't remember if it was
Oh,
for the
like your fetal position?
yeah.
I believe so. So the fetal position helps to decrease pressure from abdominal pressure.
Mhm.
So I think that's one of the reasons back in like back in 210, like first rotation, they tell you you can have them put their knees up so that so that there's decreased pressure in the abdomen when you're assessing their abdomen. So in this case, that's there to reduce some of the abdominal pressure. So
Mhm.
side lying with knees up, yeah, the fetal. Essentially, that's basically the fetal position, yeah.
Okay, cool. And then we don't know what side yet, right?
I think left.
Left side.
Yeah, I
Okay.
think yeah, I think it's almost always left unless it's like the liver and this is like the one where it's like the right side.
Mhm. And that's just that's because of the perfusion thing, because of the superior vena cava has more perfusion if you go on the left side, or is that because the pancreas is on that side and you're putting
Honestly, I'm not exactly sure. I know what you're referring to because that was a thing in OB where we put them
Mhm.
specifically to the left side because it releases some pressure from the superior vena cava that was causing like the decelerations and stuff.
Mhm.
Um, I'll try to see if I can find a re reason for why. But I think it could be either side, but I think it's more likely to, let's see, I think the pancreas location does make a difference there. The way it shifts your body, apparently. Yeah, I don't think it particularly matters, but I think most people, like the way like body mechanics works, it ends up working better on the left. But side lying should be good enough. Side lying with knees up and stuff.
Oh yeah, I don't think it matters what position, but I also read that sitting up and leaning forward as well.
Okay, I actually don't know much about that, but as long as I pretty much whatever can manage the sitting up is best is what I was reading too. Okay. Liver, it matters. I think Picker's not lying on back. Sure. But pretty much anything that helps to relieve pressure. It's just that in the PowerPoint specifically, he says side lying position. So I just go with that because that's who makes the test. But if that's another good position, that's something that you can apply to real life if you have a patient with that. And I'm sure in real life you could figure out what works and they'll tell you if it helps or not. So that's good to know though. Yeah. What was I gonna do here? For gallstones, oh, we talked about this so much. ERCP, a lap chole, they don't do open choles that much, but open chole. If they're uncertain, they'll do an exploratory laparotomy. Pleural effusions, we talked about how thoracentesis can be a thing that can be done for that. Pretty much. It's pretty much it for that. For chronic, um, I remember, I don't know if they made you guys do this. Was it for pancreatitis? No, I think I'm thinking of 220, sorry. They made us do like a practice test in 220 and it had like the most insane, I think it was for gallstones. It was for gallbladder. It was like chronic versus acute gallbladder stuff. And it wasn't even on the real test, but like it was the practice test and we were like, what the hell? It was like this crazy like 20 multiple like 20 SATA like type question. Matrix, yeah. I don't know what the hell was going on with that. Yeah, that was insane. Oh no, that sucks. That's brutal. Yeah. Yeah. So the difference between acute and cold and chronic, one's progressive, one's sudden. This one can have remission, exacerbation. It can lead to long-term issues with your pancreas, and most commonly caused from years of alcohol abuse. So when it comes to the manifestations, this is when you're gonna have that boring slash dull pain Some other things that might be specific for this would be like the diarrhea. Well, it's more clay stools. I think it's a little bit more associated with this, and we know that that can be another sign for like a sign that also exists for like cholecystitis and stuff. Because you have liver potential liver involvement, jaundice can be happening. Dark urine. Do you guys know why you have dark urine with liver problems? So in that case, this is liver. Yeah, the bilirubin is what makes the urine dark. So when you have liver impairment related to the pancreatitis, this is some of the stuff that you can get. Cool, cool, cool. Let's see what else we got here. Anything else you guys can think about? I think, oh, ascites, yeah. So that could be another thing that could be related to liver impairment. I think just the typical nausea, vomiting. A lot of these are the same thing, but yeah, good job knowing the bilirubin. Bum. Weight loss, anorexia. The main thing, very similar. The periods of remission, exacerbation, and there's going to be some symptoms that are going to be more pronounced. So something that is important here. Yes, there's going to be weight loss and anorexia. So that's like another thing that can be. So let's do the entire tab for nutrition. So nutrition, just like Ryan mentioned, you have weight loss, and that's because you have chronic, long-lasting, basically the chronic, long-lasting effects of missing enzymes to have proper nutrition, right? So if you don't have those enzymes, you're not breaking down food properly. Um, in terms of the pain, I believe they do have like different types of pain. Yeah, they'll have the different, yeah, the boring versus like probably a more sharp type of pain in terms of that. Weight loss. So another thing is that they might just have diabetes because if they have chronic, long-lasting, progressive pancreas issues, weight loss from, yeah, exactly. So all of this is related to long-lasting damage to pancreas. So the weight loss is, if they're not making the enzymes to help break stuff down, they're not absorbing things properly. You're not digesting food the way it's supposed to be. So diabetes, your pancreas over periods of time is going to have damage. So then you have that diabetes essentially going on, nausea, vomiting, dark urine, talk about the jaundice. And yeah, you can also have the manifestation of the the pseudocyst, the abscess. I think the pseudocyst and the abscess is actually more common with the chronic than it is with the acute. So it says that they can be a mass. Yeah, so these are a bit more. There's going to be more common with the chronic. So we did talk about them a little bit before. You said they can be a lower. I can imagine that from like inflammation. So then, what about some of the labs here? What do you guys think about the serum amylase and lipase? Yes. So this is similar to what we talked about with the liver, where with you have severe cirrhosis, the liver doesn't even make the enzymes to leak it out into the blood to begin with. And same kind of idea here, where the pancreas is messed up, but it's so messed up that it's not even causing a high amount of leakage into the bloodstream. So at that point, they're actually going to show up normal or low, as opposed to an acute where the pancreas is having an acute issue. And so that inflammation and stuff is causing leakage of those enzymes into the blood because it's still making a potential, it could still be making that normal amount um, and then when it leaks out, you have it high in the blood. But here, it's not working properly, so there's not enough to make a big difference, or it might even be low. See bowel sounds due to low gastric acid. But you also see HYO bowel sounds. Hypo. Oh, okay. Yeah. Due to low gastric enzymes. I would have to get back to you on that, but I do think you do have slower bowel movement. I'll double check though. It should be lower normal. It might depend on how long that's been happening, but the idea would be similar to your cirrhosis over time. It's just not even able to leak out. But yes, the hypoactive bowels, it does happen with this as well. And this is the same reason for this. Cool. Now for the management. So what are some things that can be done to help to prevent flare-ups from occurring? Yep. So yeah, some things that we can do to prevent flare-ups is avoid alcohol. Anything else you want to avoid? Pretty much like a general diet modification, yeah. So what are digestive enzymes? Yep. So that can be a thing. So digestive enzymes prior to eating makes sense. You take them before. And these are going to be your trypsin and your lipase. Yep. Yeah, high protein, low fat. High protein to help with healing. Also like moderate carbs. He says elevator normal. That's interesting. Let me double check on that. I think it might also depend on the stages. Yeah. I would always go with what he says. So even though he technically goes off Iggy, he goes off his own brain in actuality. So whatever he says in lectures, that's what you should go with. But I think it probably depends on how how much damage the pancreas has suffered. So because it is slow and progressive, probably a lot of people that have chronic pancreatitis will have maybe normal or slightly elevated levels initially, and then later on, because it is slow and progressive, later on, like way later down the road, it'll start to be more low to normal. Yeah, he makes the test. He's the boss. Yeah, you still want to eat. You do need calories, so I would say like moderate. Another thing that maybe can go in that's like small frequent meals. You'll see this one. Oh, they love this one. Kaplan loves this as an answer choice. Small frequent meals, and then yeah, they just love this answer choice. So kind of goes often. And then potentially take insulin, like ACHS, whatever. And then another thing that might avoid a flare-up is caffeine. That can lead to stimulation of a flare-up. There's also things like you want to use PPIs, but he does specify that with the enzyme replacement, the H2 blockers or antacids, as well as like alkaline foods might cause premature activation of the enzyme. So if you take the enzymes and then you have ice cream or something, that might cause the enzymes to prematurely activate before they're going to be effective. So essentially, if you're going to take your enzymes, you take it with water and probably take it a little bit before you eat instead of like taking your enzymes and downing it with milk or something. Well, let's see what else. That should be okay. And then the last thing is just the pancreatic cancer and the Whipple surgery. This one again wasn't emphasized too much, maybe the Whipple out of anything else. Uh, Pancreatic cancer, a lot of the manifestations are again pretty similar to all the stuff we've been talking about. The main thing that makes it different, I'm just gonna post it, is the elevated cancer marker here. That's pretty, which you would expect, right? If you had like a SATA and it's like, what's a manifestation of pancreatic cancer? It's probably going to be the elevated cancer marker. Um, and then everything else is very similar. I think one of the things that made it slightly unique would probably be like the blood clots or common complications thing. Um, so those tumors can have thromboplastic properties, meaning they cause an increase in production of clots. Yeah, I can imagine that being a potential risk. DIC is a lot of the time triggered by an exaggerated inflammatory response. So I'd have to see if that might lead to it, but in this case, it seems to be caused by like probably having just an increase in like clotting factors that make you clot up more, as opposed to like DIC where it's usually triggered by a huge inflammatory response, which is why sepsis kind of. So DIC is essentially your body reacting to a large inflammatory response, and your body says, "Okay, I'm having a huge um like amount of inflammation. Your body's going haywire. I'm gonna make a bunch of clots. We got to do something about it. Let's clot up." Um, a whole bunch of microclots start forming and stuff, which is why sepsis is something that can cause DIC. Um, but it might cause it. I mean, I'm sure it could. Like it wasn't really like I don't know the full patho on it, and it wasn't really clear on what he had in terms of thromboplastic properties. So it might end up. I mean, I wouldn't be surprised. I wouldn't be surprised if this is something that can lead um to that just from the inflammation, because it is a cancer, and cancer DIC can be a complication of cancer. So Yeah, it probably is what that refers to. All right. No worries. I mean, I think we all need to review some cancer stuff more. It ends up, I feel like it's kind of on the back burner. Or like DIC. Yeah, DIC is a part of, you'll go over DIC, I'll get them out in the next semester again. It ends up part of your sepsis lectures stuff. And we're almost done. We're almost done. The management for it is aiming at slowing it down. So again, I don't think the pancreatic cancer is as much of a focus. So there's very little information on it. Just kind of radiation, chemo, although it seems chemo is a little on the slower end. And then there's that Whipple surgery. So radiation and surgery, and then um, stuff. The Whipple's kind of a crazy one. I don't know if you guys saw the pictures. I don't remember if he had pictures for the Whipple, but it's kind of crazy. So this is what it normally looks like. Yeah, essentially, it's a definitely a poor prognosis, and if you can, of course, shrink the tumor. Like usually when it's radiation surgery, it's there to shrink the tumor as much as you can, try to excise as much as you can while keeping things functional. And this one's pretty aggressive, so you're really just kind of throwing at whatever you can at it. But that's kind of what's going on here. You can see that like it's just like completely different anatomy. This is like you're literally reshaping this whole combination of systems. Like completely, it doesn't even look human anymore. It's crazy. So you can imagine that this is gonna have a high risk of complications. Can you also use biliary stents for like in addition, or do you mean like I'm sure you can. Although if you look here, there's not much left of the bile duct. It's 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 like yeah, it's just not much there there's just not much there anymore if you can see from here, as opposed to this um having the slight like you have this longer because this is the hepatic duct, this is the cystic duct, and this right here would be the common bile duct, pancreatic duct. Now it's just this little piece right here. So this is a crazy little operation, high risk, poor outcomes. It's just kind of a last ditch effort to be like, okay, well, if you die from this, you would have died anyway. So just kind of quickly go over it. They're going to be MPO, NG2. They're going to be in the ICU, as you can imagine. Yeah, might as well. But yeah, because you can imagine, like, this is crazy. Like, I just look at this picture and I just keep looking at it. It's like, what the hell? Yeah, NG2, we're gonna have an IV line, probably a central line, because we were gonna want to give meds, we're gonna give fluids, potential blood transfusion, T-tubes to drain out bile, JP tubes because we did a very invasive, insane surgery. And some complications that again, I really don't think this is as much of an emphasis. So I just wanted to talk about it. So complications, as you can imagine, from having your pancreas get absolutely messed up. You can get diabetes. Of course, you can have infection. You can have hemorrhaging. The ileus, so that I guess we learned that that's the hypoactive bowel movement and stuff, which can of course lead to bowel obstruction. So that's why those are there. Abscesses, leaking of bile, more fistulas, so lots of crazy stuff. And your job is just to monitor for its stability, make sure they don't have shock. Yeah. Yeah, pancreatic cancer is pretty rough. That's pretty much everything. The only thing I think I could provide you guys with is if you are maybe having some issues with the material, I can link some videos that I think are good. So as always, some of the best professors in nursing school are actually on YouTube. So I have Nurse Sarah, Simple Nursing, and Level Up RN videos on pancreatitis. So it should be good as well as more as further review for the test. But just make sure that you do review your week one. I feel like week one is like a lot of the test because it is like 4 different. I do post the outline, so the links are going to be here. So the links will be on the PDF I give you, and so I'm going to give you guys a PDF, and I'm also going to give you guys the documents if you want to like edit it for yourself, like you want to add your own notes to it or something. That's what I've been doing with second semester. Seemed like they wanted that, and it seems like a good idea. So. Yes, I do. I'll give it to you in 1 second. I'm just gonna make sure that I got the PDF and the thing on. Yep. Let's see, what can I upload here? Date modify, that makes it easier. So here's this is the doc, so if you want to edit your own notes to it, you can whenever it uploads. This is the PDF. Here's the liver outline, liver PDF from yesterday.